Cal Beyer, Vice President, Workforce Risk and Worker Wellbeing, ACAP HealthWorks in Dallas, and Holmes Murphy and Associates in Des Moines, Iowa, will be presenting along with Brand Newland, CEO and co-founder of Goldfinch Health, based in Austin, Texas. We ask that you use the chat box to indicate any questions that you may have during the webinar. There'll be time for Cal and Brand to respond at the end of their presentation. The webinar is being recorded, and I'll be sending everyone registered a follow-up email by the end of the week, which will include the recording link as well as additional resources recommended by our speakers. And now, Cal Beyer.
Rana, thank you very much. Appreciate Kurt and each of these sponsoring organizations who've taken leadership on this really important life safety topic. We wanted to bring this topic a two-pronged approach to tackling the opioid crisis, practical and proven strategies in the workplace and at home. What I've learned working with Brand Newland over the last 15 months is nothing short of remarkable. We have the opportunity for some low and no cost strategies that can impact our families, ourselves, our loved ones, and then our coworkers in the workplace. Brand, I'm happy to have you join me today. You're with Goldfinch Health. Your core business is optimizing surgical outcomes. I couldn't talk about medical things as a risk manager, but partnering with you, a pharmacist, brought a new angle to this interdisciplinary approach. And I'm just grateful for the collaboration we've had and the opportunity to share some of that knowledge. So I just want to thank you for being here today.
Thank you, Cal. Very happy to be here with you. I just want to provide a quick introduction before we dive in here. My name is Brand Newland with an organization called Goldfinch Health. We're specifically focused in surgery, and especially around how can we help folks through a better experience, surgery and recovery, getting back to their life sooner, getting back to the things that matter to them sooner, and minimizing exposure to opioids. My personal story, I'll start early. I grew up in the Midwest, and my dad was a union member, IBEW. My mom was a nurse. And unfortunately, a couple of years ago in 2018, I saw firsthand what a surgery experience looks like when it plays out in your own life. My mom, despite her 30 plus year experience as an RN, the screen kind of went white when she was the patient, and she didn't really have much to say about the care plan that was being put together for her. She wasn't really in a position to advocate for herself as it related to the care plan, the recovery plan, pain management, and exposure to opioids, including her return to work. My dad did the best he could, but he wasn't really in a position to do that either. And it was clear to me just how important some of those conversations are as you head into surgery, and how if you are the patient, it becomes very difficult to be a self-advocate. But there is something worth advocating for. We're going to talk a lot about it today. We've got a long agenda of solutions here to preventing or limiting first dose exposure to opioids. I'm going to cover the part about the surgery. When it comes time for surgery, what is there out there that's important to know about, and what are the options that are available today that can reduce our exposure and risk around opioids in surgery? Either re-exposure for folks who've previously used them, perhaps even folks who've previously had a substance use disorder, or first dose exposure, and stay away from them as long as possible. So with that, I'd like to kick it over to the first question.
Yeah, Brand, real quickly, this is a topic that TALK has been addressing since 2016 into 2017. Kurt has allowed us to address this through the Ironworkers, and each of these sponsoring organizations has taken a stand around opioid first dose prevention strategies. And we wanted to share some of those mini tips. Big shout out to folks like Sean Neely, who's on the line today, Dave Argus, a contractor in South Boston, who's also presented with us on this topic. But in The Voice, Kurt's official publication, we've done a quarterly article in the publication around behavioral health topics. And this was a topic that's been of great interest to many of the organizations. We're going to use a polling software called Slido. If you take out your phone, don't take a photo, but just scan the QR code. It should populate pretty quickly. it might have you launch a browser, or you might be able to just go directly into Slido. Or you can go to slido.com, type in that number, and that will activate the poll. And then you'll respond to questions as we go. I found this to be a very useful tool. It's a tool then that we can share aggregated results along with the slides, and that will give you a little more insight about maybe what others are doing on this particular topic. There'll be another opportunity, but I'm just going to keep that up for a few more seconds and then give people the opportunity to opt in and participate. Again, anonymous. We will aggregate the anonymous responses, share that as one more insight for today's program. Hopefully everyone had an opportunity to do that. We do encourage Q&A. You can use the app, or please use the chat function as well. We have learning objectives that we wanted to highlight real quickly. Brand, take it away.
Yes, so this is what we're planning on covering today. Risks of soft tissue injuries, surgical procedures at work, home, and/or at play, of course, including opioids and the pain management topic. That gets into number 2, alternatives to opioids. What is known out there today, especially around surgery and recovery, and what is supported by the science as a better way through. And might be surprised to learn that even major surgery today, it might be possible to go through with better pain management and no opioids at all. Number 3, assess human and financial consequences of opioids in workers' compensation and the employee medical health benefits arena. Number 4, this gets a little bit more into my topic, these protocols, the better way through surgery and recovery, called enhanced recovery after surgery. I'll spend some time talking about what exactly that means, how it compares to the experience that maybe you've already had yourself or you've seen one go through historically, and how do you find it? How do you ask for it? And then finally, we'll close with some recommendations and tools for next steps, because it's important to both myself and Cal that this not just be a discussion of where things are, but also a discussion of what you can actually practically do for yourself, for your family, for your community, for your members. And so we'll try to leave you with some actionable steps. That
2 separate calls to action, one for family and home, and one for employers and unions that can address these very important topics. So Brand, I know that next topic I'd like you to cover as well. You were featured in the headline of this article.
Cal and I were very honored to have an opportunity to recently put together an article for the Construction Financial Management Association, CFMA. So this just came out a week or 2 ago, and you can see the logo here that led that article, and obviously very closely related to our topic today. But I thought I would just kick us off by reading the introduction that I wrote. We've been hoodwinked. We've been deceived into believing that when it comes to managing pain, the good stuff are the controlled substances, the by prescription only medications, the cousins of morphine. Now, with the fog of over 20 years of the opioid crisis lifting, we know better. We know there are safer, more effective options for patients facing the acute pain of injuries and surgery. That's not to say there's no good place for opioid pain medications. They continue to be good options for cancer-related pain and end-of-life care. For many of the rest of us, though, the risks of these drugs are simply too great.
It's really a compelling story, Brand. That article will be available to you in a handout. Here is a first opportunity for audience participation. In 2 to 3 words, describe what you think of when you hear the word opioid crisis. So 2 to 3 words, you'll type that into your keyboard. What do you think of when you hear those words, opioid crisis? A question that Brand sometimes and I ask is, how many of you have either read the book Dope Sick or seen the Hulu miniseries Dope Sick? And that was one option. But today we thought, hey, this word cloud would be a visual way of just capturing what people are thinking. And the cool thing about the word cloud, the more a word is used, the bigger it becomes. And take a look at some of these words. I'm seeing devastating, loss, death, overdose, horrible. I see construction industry, destroyed families. Brand and I talk about opioids as an equal opportunity destroyer, destroyer of hope, destroyer of life, destroyer of human potential. And that's why we've packed together. So thank you very much. you're on the same page as us. If you haven't seen Dope Sick, please share that information with your family. That's the one thing I asked my family for Christmas this year, was for everyone to watch that story. One of the articles we'll send you is our family's version of Dope Sick, when a daughter recently broke her ankle and a doctor said, I'm afraid if I don't give you opioids, you won't be able to control the breakthrough pain. And because they were educated, they were able to take the corrective actions that were necessary. So I'll go ahead and move on. I just want to thank you. But Brand, this is why we're doing this. One of these opportunities to be your best advocate comes in surgery. So why should we be concerned about surgery?
It's obviously a meaningful area, right? This is a place where so many things can go off the rails. Suboptimal surgery, or surgery done not so well, can have a pretty impactful consequence to your life, and beyond that, to the bottom line. If you start thinking about where the high cost claimants come in a population, 2/3 of them tend to involve surgery. And so it almost goes without saying, surgery is it's a relatively low incidence, but a very important area of healthcare. We can't treat business as usual. If we continue to treat surgery as it is, we're just going to continue to get the results that we've been getting. And there are people who are suffering. Part of that is related to the opioid use, and that goes for both the folks who are getting first exposure or re-exposure to opioids coming out of surgery. And Cal says this very well. There's a difference here between risk management and luck management. Risk management is being more intentional about a decision and understanding what we're getting into. Luck management is sort of just hoping for the best. And we've done a lot of that. And it's time that we move out of that. There's an update in the science of surgery that makes that possible. We're going to spend some time talking about these enhanced recovery after surgery protocols, or what it means to have an opioid minimizing approach and get ahead of the pain, stay ahead of the pain, better prepare the person who's going into surgery for that stress. We'll talk about what all that means. But bottom line, it means that we can move from luck management to risk management in this important area. The costs of surgery not done well are significant. It takes the form of surgical site infections. The co-founder of my company, Goldfinch Health, he actually lost an uncle to a hospital-borne infection from a hip replacement. That should never happen. Right? That should never happen. But unfortunately, that impacted his family. Opioid use ranges from 8 to 18%, depending on the type of surgery, in terms of persistent use after a surgery. It continues to be an issue. This isn't just about orthopedics. It's not just about backs and shoulders and hips and knees. This extends to other types of surgeries as well, including women's health, where there's a dramatic opportunity for improvement that is inclusive of C-sections, where there is much higher incidence of C-sections in our country than in other countries, and opioid use that follows it. And then finally, the readmission rate after a surgery can be quite high and expensive. The most common reason for a readmission after surgery is uncontrolled pain. It's not having a good or an understood or a shared understanding of how that pain management approach is supposed to work. And you've got somebody who 2 or 3 days after their surgery is in a world of hurt without options, right? The only options they may have at that point are the OxyContin or the Percocet or the hydrocodone, or going to the ER. And none of those are good options. And so we'll talk about how we can get ahead of that.
Brand, it's revolutionary what medical profession is capable of, and really driving informed decisions is the premise of this program today. There are some data here. I don't want to do a brain dump. You're going to get a copy of these slides. A couple of things real quickly. Quest Diagnostics recently showed positive drug tests hit a 20-year high in 2021. So that's been rising year after year after year. It's something I've been monitoring. I want to point that out. Also, in 2020, the last year full data is available. It was the 8th consecutive year where unintentional overdose from non-medical use of drugs and alcohol were on job sites. It now comprises 8% of occupational fatalities. So you are seeing more companies use Narcan on job sites. There are rules in many states. Safe Project is one organization, safeproject.us, that has a state-by-state guide of naloxone rules and regulations. Brand and I support the use of naloxone or Narcan as an opioid antagonist to reverse the effects, but that's an overdose prevention strategy. We wanted to focus upstream and prevent first exposure doses to start to minimize the problem. So I wanted you to know we've covered a lot of ground. There'll be additional data. Those were just a couple of those points we wanted to highlight. In that article, by the title of this presentation, we outlined the 3 waves, distinct phases of the opioid crisis. It's been with us a long time, dates back to the late 1990s. So 1999, that first wave, when prescription pain medication was being sold to the U.S. with the premise that it's not addictive. And we know some of the words that were used in that word cloud, scandalous. The second wave came with heroin, and that led to rising overdose deaths right around 2010. And as prescriptions have declined, people with pre-existing addictions, especially those with relapse, found themselves in alternative supplies. So Brand's going to talk a lot about diversion of medical doses left over from surgery or from prescriptions. Those are a high likelihood of ending up in a population. That third wave was with synthetic opioids coming in from foreign countries. One of those is fentanyl. So the drug supply today is dangerous, it's contaminated, and there's counterfeit medications. One good news, fewer teens are using drugs than at any point. However, they're more harmful. That's why we're seeing the rise in death rate. Over 500,000 fatal overdoses involving opioids since that onset, 1999 to 2019. My fear is that that's understated. About 70% of those overdoses in general are opioids. 73% are those synthetic compounds, namely fentanyl. And fentanyl, what makes it so dangerous is 80 to 100 times more potent than morphine, 50 times more potent than heroin. So the concerning part, even though overall prescriptions are down, we're going to share some data in a minute. Construction prescriptions are stronger and longer duration. Brand can point to some specific areas where overprescribing remains a challenge. So the pandemic also had an impact. Our industry had a challenge with substance misuse and overdose exposure before the pandemic. It's been worsened nationally, almost 30% increase in fatal overdoses. I'm aware of almost 30 states that were over 30%, and only one state that had a reduction of more than 5%. So this has been a national problem. You'll see reporting periods now. Thankfully, the CDC is doing earlier reporting. So you're finding rolling 12-month periods. The problem is not getting better. Over 100,000 fatal overdoses between May 2020 and April 21. By the next reporting cycle, October 2020 to October 2021, that number was now at over 105,000. So these are called the deaths of despair. It's suicide, alcohol, and overdose. It's affected mortality. It's decreasing life expectancy and destroying a lot of innocent people. We need to avoid those first doses to stop that slippery slope and kind of thwart that vicious cycle of addiction. We wanted to ask you a personal question. It says, my employer or union has lost a worker or family member of a worker to an overdose in the past. There's 4 choices there. Yes, no, uncertain or don't know, or not yet, but we're growing increasingly concerned by the fentanyl problem and counterfeit pills. And this is just a good opportunity for us to get a sense of where people are at. This is the organizational view. And already with these early results, these numbers are they're always shocking. It's always personal to see this. Thanks for participating. So we've got about half of the attendees who voted, and we're already seeing almost 70% can say yes at the union or employer level. So thank you for that. Hopefully you'll have an opportunity to continue participating. Brand and I just wanted to see one additional layer. This question's a little more personal. I've lost a family member, friend, co-worker, neighbor, or other person I know personally to an overdose. And we're sorry for the grief, we're sorry for the loss, but these are the stories that compel us to take action. We're going to share with you some stories of hope, help, and recovery that Rana and Palmer will send out to those of you that are registered. Again, with about half the votes in, that number is in that 68%. Could be some overlap there with coworkers and the employee, but this does show you we're not alone. And sadly, this is a new national crisis. More and more of us are exposed to that grief. So we're going to give you two quick views. Just again, try to make this a snapshot so Brand can spend more time in his area. The macro view shows really concerning data. The National Institute of Drug Abuse, it's called NIDA. They're the ones that certify testing laboratories. March of 2021 had really scary statistics. 21 to 29% of patients prescribed opioids for chronic pain misuse them. 8 to 12% develop an opioid use disorder, so an actual bona fide addiction. 4 to 6% who misuse prescription transition to heroin. Again, Brand is going to cover a little bit of this. 80% of people who use heroin first misused prescription opioids. That's the macro problem, why we need to avoid that first dose. On a micro view, it's important to really look at what happens for an individual. Again, this is aggregated data, but overall, the rate of long-term use is, quote, relatively low. People, 6% of the time, a person with 1 day of use is still using opioids a year later. Brand's going to talk about day 5 as the magic number. He's going to call it an inflection point. SAFE Project uses that same 5 days. Want to be opioid free by that point, or the risk rises. Look at what happens with an incident for over 8 days. 13.5% persistent use. If you've used for more than 31 days, almost 30% end up with persistent use. That's why this is such a problem. And then when the prescription stops, you have a persistent use, you look for alternative sources. Again, my job is the setup guy. Construction is at elevated risk. We know this problem exists. The next article in CURT was written by Kathy Dobson of Alberici Construction. It's part of the series I've been quarterbacking since 2020. It's on the impact of musculoskeletal injuries. We know there's a high frequency, high associated severity. It causes chronic pain, which contributes to sleep deprivation, which can cause or contribute to fatigue, which leads to distractions, loss of concentration, errors in the workplace from presenteeism. And we need to do more with respect to prevention of those musculoskeletal injuries. The Center for Construction Research and Training, that's part of NAB2, it's the former Center to Protect Workers' Rights, talks about 34% of construction workers having at least one MSD. What's interesting, and not surprise, more musculoskeletal injuries a person has in their career, the higher the likelihood of that persistent opioid use. You'll see a higher prescribed level of doses. So a big part of our first dose prevention needs to be eliminating the cause and source of sprains and strains. This next article in CURT is 2 pages chock full of best practices. I'm excited about that, and a big hats off to CURT for the continuing leadership in this space. When Brand and I and my teammates talk about culture and the demographics of construction, we know that tough guy, tough gal, stoic mindset. We have that play through the pain, and it's driven by a production schedule, but it's also a possible source of, if I'm not at work, I'm not getting paid, and then I'm not banking enough hours for future benefits. that keeps people from seeking care. I get agitated when I read this, but construction is the second highest among all industries for opioids. 55% of the time, people in construction were prescribed opioids. The National Council on Compensation Insurance said despite a 49% reduction in per claim opioid use, construction had 2 times higher usage than all other industry groups. And when we got a prescription, 20% stronger, 20% longer. In some ways, it feels like our industry was a perfect storm for this opioid crisis. We can do better. So my job is to be that setup guy. The first dose prevention strategies. There are pouches exist for safe environmental disposal. Don't dispose down toilets. It ends up in the water stream, contaminates groundwater and fish, and then it ends up in our food cycle. One company is called Deterra. They have drug deactivation pouches. One of the resources we're going to send you is you can get a free pouch during the month of April. They'll send it to you. It's large. It's free. You can put in patches. You can put in liquids. You can use pills and other formats. So that's one strategy. Second, most national pharmacy chains have prescription take-back kiosks. I asked a pharmacist recently how often they have to empty that. And he says, well, regularly. Unfortunately, we get more use from shoplifters disposing packaging than we do prescription medications. But that is a free service available at most major community-based pharmacies. Third, we did a webinar recently. We asked the question, 70% of people did not know that there are lock boxes for prescription and over-the-counter medications. $35 is a typical cost, and it's a great tool proven to prevent access by children and teenagers. It minimizes the risk of diversion from medicines that are not secured and locked. The next strategy deals with workers' compensation. This issue is challenging because every state has its own jurisdictions, their own formularies, their own procedures. I happen to live in Washington State. This has been on the priority since 2014. There's more monitoring in this state than was done in most states and done earlier. Doesn't mean there's still not potential exposure, but we as employers, both labor and management, need to do more, have more oversight, ask tougher questions, demand safety in the medications that are being prescribed, especially in the surgical side where non-opioid medications are in existence, or where Brand's going to talk about multimodal pain relief. So workers' compensation, there's opportunities for improvement. It could start with data analytics, asking your providers, TPAs, and carriers to share information so you can at least make those informed decisions. Brand mentioned that C-section, 31%. Having perinatal care prior to, during, and after delivery is what perinatal stands for, can reduce the risk of preterm labor and decrease the number of cesarean deliveries. One of the resources I'm going to send you makes this a real personal issue. I've got 5 kids. We went through those pregnancies. Today, it's scary. The number of complications has risen. The next one I want to highlight would be in those employee benefit plans. You've got the opportunity, if you're self-funded, unions and employers, to make more direction. You have more control. You can specify in your formulary. You can ask for those non-opioid medications. You could institute a pre-certification for inpatient and outpatient procedures. So you're putting another set of eyeballs on that approval process. That can decrease the exposure of opioids. And Brand's going to highlight those enhanced recovery after surgery. People say to me, hey Cal, as a risk manager, you're worked up about surgery because I know too many people whose first dose was a dentist, a surgery, a C-section, or other form of surgery. And the number one strategy that all of us can learn from Brand is this multimodal pain relief. When I was a risk manager for a contractor, I probably made HR nervous, but I was having conversations with employees about these risks, the consequences, asking doctors the tough question. And what I want to say before I hand it off to Brand is the majority of us have a power separation. We didn't go to law school, or we didn't go to medical school, excuse me. We don't necessarily know how to talk to doctors, and they don't necessarily know how to listen to us. We need an advocate. And Brand, you're that person. Thanks for joining us. I know we've got to cover a lot of ground, but this is a great opportunity to start that conversation.
One comment before you dive into this, given where we've been through the pandemic, I know there's been some folks, and Cal, I hope you don't mind me mentioning this, you may have held on to a medication in your medicine cabinet because you didn't want to end up back in the doctor's office or back in the pharmacy trying to fill it. So you're hanging on to that pain med or cough syrup or whatever it is that includes a codeine, which is an opioid. Now's the time to take a look at that medicine cabinet and get rid of what's there left over from a past prescription. It's worth it. It's dangerous to be there. You don't want that falling into somebody else's hands. And the drug may not be good anymore anyway after it's been there for a few years. So that's public service announcement from a pharmacist. But I want to dive into a little bit more on the surgery side and start with an example. This is a guy named Mitch and his family. It's an actual patient that we worked with. He's in construction in Pacific Northwest in Portland, and he needed a shoulder repair. And so he started doing some work as an informed patient to find the right surgeon in his area to do that repair. He found a great surgeon in Portland. He was on the track towards preparing for that procedure. That's when we got involved. Kate Emerson, pictured on the slide, is a nurse on our team at Goldfinch, and she was working with Mitch, making sure he understood the options that now exist around a faster recovery to your life and to your work, also minimizing exposure to opioids when going through a major surgery, even a major surgery like a shoulder repair like he needed, which can be painful. And so that eventually led to a three-way call between Kate and Mitch and the physician that had been selected, going through the final stages of planning. And Kate nudged Mitch in a way to bring up one final topic. That final topic was something that he hadn't brought up in the previous visits with a physician, but an important one. He was concerned about exposure to opioids because he has family history of addiction to painkillers. Very relevant to his care path, important to him, and just not something that he had felt confident in bringing up. Once it was on the table, the surgeon sat up a little straighter and said, "Thank you for bringing that up. I now understand why it's so important that we're going through these other steps, these steps being the enhanced recovery after surgery steps I'm going to talk about." And so Mitch got that pre-operative pain management approach, better optimization for the surgery to come, minimizing the need for opioids. He went through that shoulder repair, and he was actually back to work within 1 month when originally he was told it was going to be at least 4 months. And so a great success story for him, great success story for his family and beyond because of the minimization of the opioids. Now, a few things I want to hit on that are just kind of setting the stage around surgery and opioid use. You may have seen this yourself as you've encountered surgery or seen loved ones or others go through surgery, but just a few key points here. And Cal already introduced this concept of day 5 being an important day after surgery and use of opioids. We're not in the position to say that there's no place for opioids after surgery. In some cases, there is. It is possible. We'll talk about how you can go through surgery today without that exposure. But what is critically important is getting away from use of opioids by day 5 after the surgery. And the reason for that is the studies very clearly show time and again that if you're still using the Percocet or the hydrocodone on day 5 after your procedure, regardless of what the surgery was, you are much more likely to still be using that at 1 month after surgery, at 90 days after surgery, even a year later, if you can believe it. So if you look at these graphs that are created, it is very clear that if you're still using that opioid approaching the end of the first week after surgery, you're going to be on it for a while. Second thing I want to hit on relates to use of opioids. Studies show that patients use 27% of the opioids prescribed to them, regardless of pain, which is really an incredible finding if you think about it. I think it might have something to do with all of the messaging that's been out there around finish your prescription if you want to be a good patient, right? And that's really related to antibiotics when you have an infection. It is a good idea to finish your prescription to be a good patient there because you don't want that infection to come roaring back. With pain, though, it's the entire opposite, right? Especially when it comes to a medication like the class of opioids. We want to use as few as possible and then get rid of the rest, right? Get it out of your life, get it out of your home. But we haven't quite messaged that clearly yet to patients, and we can see it here. Patients use 27%, no matter what number they're prescribed and no matter their pain. Withdrawal, persistent use, addiction. Withdrawal is what sets in around day 5. That's the connection here. If you've seen this yourself and talk with folks all the time who've had kind of the first inkling of this, or they've been through it themselves, or they've seen it in their family, you stop using an opioid after consistent use throughout the first week, you don't feel well. And you're not maybe sure why. You take an opioid, you feel better. Maybe it's better managing the pain. The better chance is that you are treating your withdrawal symptom and feeling better because you've taken the opioid. That's what's so dangerous and such a slippery slope about these medications. 80% of heroin users, heroin is an opioid, obviously an illegal one, of heroin users reported beginning with opioid use. They started with a valid prescription, most often through surgery, but it could be through other uses like dental or low back pain or something else. And then that runs dry. They're no longer able to get a prescription or don't feel like they can go ask for another prescription, and they head to the street. And that's where you find a heroin user. That's also, frankly, where we find folks who are buying medications on the street, drugs on the street that are now laced with fentanyl. And that's how we end up with these overdoses that are happening day to day, given this third wave of the opioid crisis. Last thing I want to hit on, this is about more than the surgical patient. This is more about the person who, more than just about the person who got the prescription. It's about that person later, not just this initial exposure to opioids, but what that means to them the next time they have something painful, even more painful, where they maybe really need opioids that next time. And it is definitely about the family and the community around that patient. If there are leftover pills, that is where so much first use exposure happens. It's sitting in the medicine cabinet. Some guy is in your house mowing the lawn or doing whatever, a family member, a child, whatever the case may be, and there they are. And that can be too enticing for some folks. This is a look at opioid dependent analgesia, so pain management, based on type of surgery. How likely are you to become a long-term user of opioids? And so you can see this isn't just about orthopedics. The top one on the list is colectomy. So that is removal of part of your colon, part of your GI tract. Usually that's for cancer. That's top of the list. Almost 18% of those patients become long-term users. And you can see down the line, there's hysterectomy, very common women's health procedure. There's a number of procedures you would expect to see here from the orthopedic side as well. Rotator cuff, total knee, total hip. It's very common to start with surgery and end up using an opioid for months on end, and far too common. It doesn't need to be this way. That's what we set out to try to change. Cal, if you wouldn't mind advancing to our first question in this section. So multimodal pain relief is an example of an enhanced recovery after surgery protocol. And this is a little bit of a pretest. We haven't quite talked about this yet, but can be started before surgery to get ahead of the pain. Is considered to be an opioid sparing technique, can incorporate non-opioid pain medications. All of the above, none of the above. So I'll just give this a second. All of the above, if you've learned the tips for taking the test, using the test to take the test, this would be a good example of that. It is all of the above. That these multimodal pain management using different types of non-opioid, non-addictive pain meds we're going to talk about as being part of these protocols for all of the benefits that you can see here. So diving a little bit more here into surgeries, 90% of surgery today is more invasive than it needs to be, and that goes beyond the size of the incision. We'll talk about this in a second. For many procedures, most patients today, there is a smaller incision that's possible, laparoscopically, robotically assisted. There are advances scientifically that can lead to a smaller incision and thus less healing and less pain. But this is about more than the size of the incision. This is about the size of the opioid prescription that comes with that surgery. It's about the length of time out of work, right? Those are other ways that surgery becomes invasive to your life in ways that you don't want it to be. invasive surgery, number one gateway to opioid addiction for the reasons we just talked about. Valid prescription to start off, it ends up in a refill, it ends up in perhaps illicit use later. So what I want to spend just a moment talking about is, what do I mean when I say enhanced recovery after surgery? What does this look like compared to the status quo of surgery, maybe surgery that you've already had? Hopefully you've seen, if you've had surgery yourself, maybe you've seen some aspects of enhanced recovery, but just want to put a fine point on this. So what you're looking at is surgery and stress, both physically and psychologically, to the person who's going through it. So first thing I'm going to show you is the typical experience in surgery, and then cover just a few elements of what this means to go through this better approach. So the very common instruction that you may have received if you've been through surgery yourself, or you've seen someone go through it, sounds something like this: don't eat or drink anything after midnight the night before surgery, right? An expectation that you are totally fasted, probably dehydrated as a result of it, and almost certainly probably not that happy about what you just had to go through in preparing for your surgery. You're already stressed, and you haven't even gotten into the stress of the surgery yet. And that's sure to be a stressful event. Turns out to be totally unnecessary. It hasn't been supported by the science or the professional societies of medicine since the 1990s. There's a better way through. I'll talk about what that looks like here in a moment. What happens next, unfortunately, for many patients is an unnecessarily invasive procedure, a large incision when you could have used a different approach, when the surgeon could have used a different approach with smaller incisions or an advanced technique. The stats show over 60% of surgeries are done in that invasive manner today, when fewer than 10% should be. There are certain cases where there's no avoiding it, but far more cases should be done minimally invasively than are done today. So now you've got a patient who has a lot of healing to do, large incision, large surgery, they're coming out of that. They weren't really prepared for this, nutritionally and otherwise. And now they're getting hit with a pretty heavy dose of an opioid. Usually it's oxycodone, sometimes it's hydrocodone or tramadol, even fentanyl at times. You've got a lot of healing to do. You've got a long road in front of you, and it's going to be painful and it's going to be expensive, both to that person and to the groups that are paying for that person to be out of work and for their healthcare. And it could have been avoided. So the way to avoid that is based on these enhanced recovery protocols. These have been around for over 20 years, widely studied, just not widely adopted. You're about 5% likely to find this on your own. This is really the inspiration for why we started our company, Goldfinch, is folks need help asking the right questions and finding this. And this should be the standard of care. It needs a nudge to get there. Healthcare changes so slowly, we need a nudge to get this done. And that's what we set out to change. So just to give you a couple of examples of what this actually looks like. One is around nutrition. So what is better than fasting for 12 or 14 hours before surgery? The better approach is actually pretty straightforward, simple. It's a Gatorade. A Gatorade up to 2 hours before surgery spikes your blood sugar, brings hydration, brings electrolytes in the case of Gatorade, and doesn't increase your risk of the outcome that's always been avoided by avoiding food and drink leading up to surgery. And that's called aspiration, which is literally ending up with food or drink in your lungs because of your airway being relaxed under anesthesia. It does not increase the risk of that. Now, it's out of your stomach in 90 minutes, so you're safe. What this does is really profound. There was a study that looked at just the Gatorade piece of this out of Harvard a few months ago for hip and knee replacement patients, very common procedures. What they found was $1 on a Gatorade, same Gatorade you might already have in your house, you can have at 7-Eleven in 10 minutes, saved a night in the hospital. It was 2 nights on average for the Gatorade group staying in the hospital and 3 nights on average for the non-Gatorade traditional approach to surgery. So you spend $1 on a Gatorade and you save thousands of dollars in an overnight hospital stay and everything that comes with that. What we want in our healthcare system today is get care at the hospital and then get home, or get care at the surgery center and get home to heal. That's the best place to heal, and this is a way to do it. Second thing I want to talk about is pain management. What's better than the opioids? So that's this multimodal approach that we just talked about in the question. Multimodal means using different types of pain meds, non-opioid, non-addictive, to treat the pain from every angle. Right? So we're using medications like acetaminophen, which is Tylenol, at a higher than over-the-counter dose. We're using anti-inflammatory drugs like an ibuprofen, and often 1 or 2 other pain meds. Really revolutionary part of it is start it prior to surgery. Get ahead of the pain, stay ahead of the pain. And what's surprising is in the after-surgery period, Tylenol and Advil, 2 drugs that are very common, they're generic, they're in every gas station in America. Taking those 2 drugs on a scheduled basis and staggering them throughout the day is actually 3 times better than oxycodone in managing the pain. I'll say that again, Tylenol and Advil, 3 times better than oxycodone in managing the pain, and doesn't come with all of the side effects, the sleepiness and the lethargy and the constipation and the addiction, right? All the things that we know are part of use of opioids. So if you can combine the multimodal approach and you get a minimally invasive surgery, you've got a really good setup for a much different recovery, even from major surgery, back surgeries and hip replacements and knee replacements and shoulder surgeries and hysterectomies and cancer procedures, et cetera. Across the board, this applies. You've got a patient who's much more prepared to get up and start moving and start to resume normal activity sooner. And the real secret to this is if you're in a condition to do that because you're not drugged up on opioids, that movement leads to healing itself, which leads to more movement. That's how we see things like we supported a woman recently through a hysterectomy. That's typically a 7-week recovery. Well, she didn't use any opioids. We helped her to ask the right questions, get some changes to her pathway or care pathway with her surgeon. She came out of that procedure not having used any opioids. And she brought up to our nurse on day 4 after her surgery the idea of going back to work. Again, 7 weeks is the typical recovery. She's talking about it on day 4. She was back to work in 1 week. And so that was a great story for her. Surgery was a distant memory, blip on the radar, not something that impacted her long-term, back to doing the things she needed to do, loved doing, which included work for her. It was also a success story for her employer. She's a school teacher. So when she's not there, somebody else has to be there, right? And so not only is she getting back to work and back to a full wage, but the employer in that case is not having to pay for her to be gone and paying for the complications that could come with her being out of work longer. A success story for everybody. The last piece I'll just mention quickly, often part of these enhanced recovery protocols and what we drive on is being very important. There's some physical aspects of the stress of surgery. There's also a pretty significant psychological aspect, right? Which you can boil down to this question: when will I be back to normal, or will I get back to normal after surgery? And it helps to have somebody who's an expert that you can ask. You don't have to feel embarrassed to ask, or don't feel like you're encroaching upon their day, to have a nurse who you can call or you can text and ask simple questions, or even more complicated questions about your surgical recovery. That's the formula for getting somebody back to their life and back to work in what is generally half the time that we would otherwise expect. This is a look at hernia, a very common type of surgery to repair hernias. And this is recovery days. So you can see across the bottom how long somebody was out of work. So you can see most people getting a hernia repair are back to work within about 60 days. If you look out, though, there are some outlier cases here. And these are the ones that we especially remember because those are folks who are out for 3 or 4 or 5, or there's a person here who's almost gone 12 months from a hernia case. And not only were they, I'm guessing, out of work that long, that was probably because there were some other complications with significant expense. So these tend to be the high cost outlier cases, both in terms of time away from work and disability, as well as the healthcare cost side. What we're ultimately doing by bringing these protocols into place is shifting away from those outlier cases. It's kind of an insurance policy to say, we're going to reduce the risk. We're going to risk manage here rather than luck manage, risk manage away from these cases that just really get off the rails. It does have an ROI. So this is a feel-good story for sure. Every patient who goes through this comes back and says, this was much different than I expected, and for the better. I expected to be in pain. I expected to be out of work and away from the things that I typically do in my life for a much longer period of time than I was, but I wasn't. And that's just fantastic. This was much different than the surgery I had 5 years ago or the one I saw my spouse go through. All of that's great, but I also understand, and we understand, that there has to be some financial ROI for this to be a commercially relevant program that we're talking about. And so there is. What we're looking at here, this is a 1,000 employee population or 1,000 member population you can think about. Generally speaking, there's a 7 to 8% incidence of surgery across the range of surgeries we're talking about per year in that type of a population. And if you compare the experience of getting enhanced recovery and having a nurse supporter, an educator, an advocate through that experience with the typical experience, and there's a third-party database that we use as a comparator, that is where we show saved days in recovery time. And so if we aggregate saved days over the course of a year for these 75 procedures across the range, it's about 16 FTEs, 16 full-time folks over the course of a year that we're saving in recovery time alone, which has significant cost advantages. Of course, there's also healthcare cost savings here. We're talking about avoiding the readmissions and the rehospitalizations and the reoperations that occur, and even the opioid addiction that has cost, certainly economically, and also has a humanistic cost. So you look at the statistics for this population, you would expect over the course of the year about 7 new persistent opioid users because of surgery alone in this population. What we see in our program, Goldfinch, is saving over a month in recovery time by effectively using what we now know from over 4,000 journal articles on enhanced recovery and just getting it to happen. Really what we need to save is 5 days to break even on. We charge about $1,000 a case, and we're well above that. A few closing comments here. COVID puts us in a unique situation based on the impact on healthcare. There's been a delay of care, right? And if we go to the next slide, we can see this. This was actually a union group that we looked at the data. We could see the drop in shoulder and knee and hip procedures in the midst of COVID, but those procedures don't go away, right? What happened, if we go to the next slide, you can see that what went up was steroid injections, which prolongs the need for surgery. Unfortunately, those steroid injections don't last forever, and they actually end up putting a patient in a position for a more deteriorated joint at some point. As you're on that joint longer, the wear and tear and the steroids actually eventually eat away at the cartilage itself. So you're still going to need that procedure at some point. That bill's coming due. What we're afraid of is not only is this happening, right? There's been delayed procedures whenever possible, and sometimes they were forced to be delayed. There's also hospitals that are kind of in the midst of catching up, right? They haven't had full schedules of surgery for 2 years, and they're in the midst of starting to catch up on those procedures. And the last thing we want that to lead to is a rush to low quality surgery and a rush to the easy button, which ends up being opioid pain management. And so that's really what we're focused on trying to change. Sometimes we get asked about how do physicians react? Will they change? Bottom line is most physicians will. There's a certain group of physicians who've already adopted this, about 5%. There's a big middle group that when they have an informed patient with a reasonable demand, that's how our chief medical officer says it, they've got somebody who's asking or someone who's asking on behalf of the patient, an advocate, they will change. Right? There is a group, as you might imagine, there's a group of people who are stuck in their ways. They're not going to change. And at least we know, right? At least we know that that's the setup, and we may not be able to change everybody, but most people are willing to change. And once they see the benefits themselves, they tend to change their practice overall. One kind of final comment, we sometimes go through what's called a surgery quality analysis. We'll look at the actual data for a group and see, it's nice to see that there's, or helpful, maybe not nice, but helpful to see that there is trends that show that there's a need for better quality surgery. But what's most useful is to look at your own data, right? Look at the own data and what do you see in terms of surgery quality and opioid use. This was a union group that we looked at, and what we found was frightening. Despite all that we know about opioids and some of the measures that have been put in place in certain states around prescription drug monitoring programs and edits with pharmacy benefit managers, et cetera, there's still a tremendous amount of opioids prescribed in the surgery space. You can see around back surgery in this particular population, 341 doses on average per patient in that spine laminectomy category. In hip replacement, there's 161. There's a group called Michigan Open. It's a coalition of folks who've come together to recommend what is a good benchmark for the number of opioid doses that should be prescribed after surgery. What they came up with for hip replacement was 30. And so we're well above that, 161. And for knee replacement, they came up with 50 as the benchmark. And we're seeing in excess of 5 times that in the real world. So there's still a lot to work on there. We have a number of resources at our website, goldfinchhealth.com, including a set of questions, 10 questions to ask as you go in for a surgery. If you go in with these 10 questions, asking about opioid minimization, asking about enhanced recovery, asking about what your recovery is actually going to look like, you're immediately a different patient that they see all week and all year. You are in a different category, right? That you're advocating for yourself or someone's advocating for you, and you're much more likely to get a different experience because of it. And so there's those tools and some others available at goldfinchhealth.com.
Brand, I think what's interesting, this opportunity to be your own advocate, You have to be educated to know that these first exposure prevention strategies can minimize and improve quality of life. So we wanted to just anchor this learning, enhanced recovery after surgery. What this has done is allows us to be an advocate for our families, for ourselves, for our loved ones. It also allows us in the workplace to look at this more strategically, to make informed decisions, and to help people who are in the recovery community, long-term recovery, who delay surgery because they're afraid of that opioid risk. So I think there's so much opportunity here to drive life safety, life quality, and then impact productivity in the workplace as well. All of the above is that correct answer. Wanted to let you know if we moved to the call to action, and then we'll get to those quick questions. You're going to get a copy of these slides rather than me and Brand read these off. What's really important is we felt there are 7 actionable steps for home and family, and we have 7 for employers and labor unions. Some of these will be no or low cost. $35 for a prescription lockbox as an example. You've got that doTERRA drug deactivation pouch. But having the conversation, letting people know what those risks are in your family, in your home, extended family. And then we wanted to teach you about multimodal pain relief, let you know that there is an alternative to average result surgery that you can optimize, and that can have a big lasting impact, reduce the risk of addiction. Likewise, there are 7 steps here. 4 is combined. There's 2 if you have a self-funded employee benefit plan. But again, it's education of employees. Talk about harm reduction, and then using data analytics, driving the leave process and accommodations, pre and post-surgical. And then doing that surgical quality analysis, look at your high cost claims, look at the percentage of opioids, look at the delayed surgeries, look for opportunities to have an impact that can have a high ROI, as Brand indicated. And then that perinatal care program. So we focus a lot on those self-funded because you have more direction, more control, more opportunity. Rana, I'm going to pass this off to you for questions. We know we covered a lot of ground. The article you're going to get is going to give you more detail, more exhibits, more sidebars with more data points. It's very well researched. It's going to have a lot of practical data for you to help impact family and the workplace. Are there questions, Rana, in that chat that you wanted to direct to me and Brand in the time that remains?
Yes, there were some questions that were actually sent directly to me through DM. So the first one is, I've been told that pain medication actually helps you heal faster. Is this true?
Well, the only way it would help heal faster is if it allows you to get up and move, right? So that would be the kind of mechanism. If you're able to get up and move because of the treatment of the pain, then yes, definitely. I would suggest that medications like acetaminophen or naproxen, which is Aleve, or ibuprofen, which is Advil, if you can treat the pain with those medications before you get to the opioid, that allows those medications don't have an impact on your cognition and allow you to get up and move and not be sort of sleepy. And so getting up and moving on those medications better than doing so on the opioid.
Thank you. Another one, Bran, is do you find that many health insurance companies require you to use pain meds before getting an epidural, for example, for back pain? And then an add-on to that is, if so, how do you get around this barrier?
Yeah, there is some what's called step therapy around maximizing pharmaceutical options or non-invasive options before you go with a more invasive option like an injection or furthermore a surgery. And so you may have to go through some of those steps. If it's an opioid that's required, what ultimately is needed to work around those steps is the physician who's willing to go to bat for you and go directly to the insurance company and say, this is a circumstance where this just isn't an acceptable step on the way towards a non-opioid option. An opioid option on the way toward a non-opioid option is just not an acceptable step. And so that's ultimately what is the kind of workaround is getting your physician on board, getting the right physician who's on board with that approach.
And from the chat box, do you think the legalization and wider acceptance to marijuana usage may have contributed or led to the higher number of positive drug tests? How has the wider acceptance impacted, and it's SUD, I don't know.
Substance use disorder.
Thank you.
Thank you, Rana. Yes, I think there's clear information to that point. I think our industry continues to struggle with legalization when we've got federal mandates making substances illegal. The challenge has been testing methods and criteria to demonstrate the presence of metabolites for marijuana, whether it's legal or recreational, so legal, medicinal, or recreational. Does not necessarily equate to impairment. And so that would bring clarity to this issue. I think there is evidence in some states where it's been studied that the legalization has been a gateway to other medications, has allowed for people to experience that contaminated or counterfeit drug supply. I think it's let the guard down that it's okay. The interesting thing, teen use is down. Unfortunately, teen deaths are rising because of that contaminated drug supply. So despite fewer users. So Rana, this is a story that continues to unfold. It's one that we pay a lot of attention to. From an employer standpoint, many of our owners with Kurt would have very strict policies requiring zero tolerance, and contractors and labor unions are doing their best to educate employees. We need to really look at breaking the stigma of substance use disorder, and we need to educate employees beyond a drug test about the risks. And by making this approach available, I think it's going to help address some of that hidden exposure to substance use that we don't often talk about in the workplace. We talk about it in terms of drug testing. We don't talk about it enough in the prevention and the risk management.
Cal, just one thing to add. I'm higher level, very optimistic about what we might find in the marijuana plant over time in terms of other pain management options. THC, which is the mind-altering chemical in marijuana, is what we know about. And we also know about CBD, which is another chemical, right? Those are two. But there's something like 400 plus different chemicals in the plant, cannabis plant. And there's some real optimism that some of them may turn into valid pain management type options, and probably other types of drugs also in the future that are available through more formal pathways, right? Not kind of this gray area that we're operating in right now, that they would be prescribed substances or at least regulated by the FDA in a way that they aren't today. So I think the future there is bright. We're in a weird sort of troublesome time period right now that causes these issues that we're seeing.
Well, thank you very much. We are actually over by a couple minutes, so I did go ahead and in the chat box is my email. Anyone who has any questions, please don't hesitate to forward those to me, or Cal and Fran have their information on screen here. If you choose to send your questions to me and you would like them to be made public, the responses, just let me know, and we will include that in our follow-up. And on that note, I would like to thank Cal and Brand on behalf of Kurt and Talk Impact Mechanical Insulators LMCT. We really appreciate your sharing your valuable knowledge, and we look forward to having you continue in your quest to ensure that we are all safe. Thank you so much.
Thank you so much, Rana. Thank you, Kurt, all sponsors. Appreciate everyone joining us today. Thanks for your participation. If Brand and I can help you, don't hesitate to send Rana questions. We'll provide detailed replies. Thanks so much, Rana.
Thank
Thank
you.
you.
Thanks, everyone.